next is now the clinician point of view with Bernhard Wörmann, hematologist, professor of hematology, oncology, and the medical lead from the German Society of Hemato-Oncology and the European Hematology Association. Thank you to be there. Thank you to speak for all the clinicians, and some of them are in the room.
Well, there's one difference for clinicians. The modern Hippocratic Oath does not allow acronyms anymore. So fortunately, everybody has fulfilled the expectations which I had in preparing my slides, so I can focus on the clinical viewpoint. One of the important points is very similar to what François says. We get the same questions from clinicians than you get from the patient aspect. What is it all about? They don't know about it. So HTA is not part of the medical curriculum. We just don't have it, so we have to explain it. And when Robin has the European Affairs Department at EAA, you have 10 to 15 countries involved, but there is still a lot to work on. So I think exactly as you mentioned it, if I made this very simple for clinicians and national societies, the very right side is what we know, but even in that red bar, not every medical society is involved on the national level, so probably only half of them in the EU. And now if we add the new dimension of the purple bar, where they have to get involved, then I think we had initially thought that it was important to get involved in the JCA discussion, and now it turns out that probably the larger and bigger challenge is to really get them informed about PICO and about what they can do early on to influence the procedure, and also to make sure that what comes out at the end is useful for them on the national level. So I guess PICO is important, but it's not the way I show it here. It looks like it would be equal importance, but I think for us it would better be demonstrated in this way. Probably the most important and most difficult initially is to look at the right comparator, and I'll come back to that. Of course, population is important because we know that it's quite different. Indications may vary, even within what EMA has approved. And outcome parameters, again, also may vary, like also discussed it, is overall survival, quality of life, progression-free survival at the same level of importance. So if we talk about comparators and we talk about this model of comparative effectiveness, of course, first you would think, well, it's easy for medical societies. You have your guidelines, and so if you have a guideline, then that's what the comparator is. Well, yeah, that's correct, but not all guidelines are really recent. And most importantly, the access to the new drugs which have been approved within the past 10 or 15 years very much influence if the guideline can be used or not. And that's quite different in many countries. If they have no access, the guideline is nice to have, but if you don't have the drug, it doesn't help you. So we came up with this kind of draft. I apologize if it's very small letters, but basically it says that if there is a question for JCA or the JSC, then the EHA as a coordination could prepare a draft, and the important bar is the colorful one. Then we go to the nations and ask them if you can align with what we proposed. But again, this line of colors is not equal, because initially when we started, we don't even have a person in each country to talk to. So what we did in the summer after consultation with national societies, that we started to set up a network of experts in each country. And the way we thought to do it was to get them involved where they have some benefit. So what we passed this summer is, we did a survey on access to EMA-approved drugs within the past 10 years. And we thought, well, that's quite important, especially as I pointed out, guidelines are nice to have, but it's important if you have access to them. And that's 142, so that's really a good number in hematology. And of course, hemato-oncology is the bulk part, but we also have classical hematology and also coagulation with hematology. So we sent them a questionnaire to each country with 142 questions and ask them, do you have access? Do you have no access? And also, do you have limited access? We were very, very surprised that's the current status. We got back 38 completed questionnaires. Now, well, the EU has 27 countries, but there were 15 who were non-EU who wanted to participate. they really felt left out. The very first ones who pointed out were the UK people, the Swiss people, Turkish people. They wanted to get in there, which is wonderful. But so now we have a large EU. And this is how it looks, and that's quite impressive. For us, it was initially started slowly, but really then it took some pace in the summertime. So only the black countries are not involved. So that's Northern Macedonia, that's Bosnia-Herzegovina, that's Belarus and Russia, and all the other ones have participated. And this is the kind of information that we now have. So if you look at this antibody conjugate for Hodgkin's disease, second line approved after autologous stem cell transplantation, you see that about 80% have access to it in Europe. A small number have no access, and again, a small number has some limited access, so there are some limitations to really get the drug. That's probably one of the older drugs. If you come to a newer one, like first-line treatment in multiple myeloma, daratumumab, which prolongs survival, but again, only about 60% have access. The number of no-access countries is much higher, and the number of countries that have limited access with a lot of creativity to get access to the drug is about 1/4. So it's quite important because you already see guidelines are nice to have, but if 40% or more don't have access or have limited access, then that can't be the complete reality. And if you go like this one, that's a new one. In hemophysiology, if you activated factor eptacoc beta for hemophilia A and B with inhibitors, the vast majority has no access. Why is this important? Well, if you look at ATMPs now for hemophilia, gene therapy, it's quite important what drugs you have to compare it with. And if you have a drug or another drug which is already active, like imicinumab with inhibitors, you might not be that under pressure to have a gene therapy, but if you don't have access, it just changes your view. So in summary, yes, we have this survey now, and probably I should also just underline, we have 42 countries participating, and we have 155 colleagues who participated in the survey. So I think that's important to set up a network. Now we have a person to talk to in these countries, but you also have more people who get involved, and we had a large conference presenting those results. So I think it's one way to build up a network of experts. Last point. Yes, I think this is the draft that we have. Guidelines are fine. Access is quite important. I think it's important to have these drugs, to have these data. And of course now, if you look at clinical benefit, then we have some basis also for the countries to discuss with. When you talked about clinical benefit, you probably remember that we talked about the ESMO benefit scale of clinical benefit, which is not the same as grade. It's not the same as HDA. It has some other parameters. It really focuses on clinical benefit. And we had a gap there in hematology. It was only for solid tumors, but not for hematology. And this gap was filled. In September, now we have an assessment of more than 100 hematological drugs with the MBCBS scale, so we can compare it to HDA assessment and have a clinical benefit kind of as guideline. This is what we have. This is a summary which is published also and validated. We have either on the left side a curative approach, on the left side a non-curative approach, and we have parameters to say this is a substantial benefit or not, so we can also compare it to HDA methodology. So that's the current status. The door is wide open, but not yet for everybody, and I think the way we did it probably might be an example for other societies also to try to build up these networks, which we definitely need if we want to have experts involved who are experienced, and you can also handle the results that will come out in some years and will have to be used on the national level. Thank you for your attention.
Thank you very much, Bernhard. Once again, maybe several questions at the time of the discussion.